Hello, and welcome to STAT's second installment of the 2022 Status List Spotlight Series, Leading JAMA Through Turmoil, featuring Kirsten Bibbins-Domingo, sponsored by YouTube. Thanks for joining us. I'm Usha Lee McFarling, National Science Correspondent here at STAT. And I'm sure you all know how Zoom works by now, but before we get started, there's a few quick housekeeping items. At the bottom of your screen, you should see several icons. Use the chat feature to talk amongst yourselves or send a message directly to the STAT team. Please do not put your questions for us in that chat, as we won't see them. If you do have a question you'd like to ask during the event, please use the Q&A feature to type your question and we'll try to answer it live. You should also be able to upvote questions that you find interesting so that we're more likely to answer those. We will be taking questions throughout the chat, so don't wait till the end to submit. We really love to hear your questions and your voice. It's part of what makes these events engaging and fun. We want to hear from you, and thanks again for joining us. Before we get started, I'd like to welcome Dr. Garth Graham, Director and Global Head of Healthcare and Public Health and Head of YouTube Health, for a sponsored introduction for today's event.
Thank you, Usha. And as you said, despite us working with Zoom for the past 2 years, I'm still challenged working and getting my camera on in time. So thank you all, and we're honored to be partnering with STAT to bring this event to light. More importantly, honored that Dr. Bibbins-Domingo is joining us to just impart wisdom in terms of her experience and the amazing things she's done, particularly around health disparities, health equity, and so proud many of us are to see her leading JAMA and where she'll bring that organization in the future. From us, our interest in general is, mine in particular, has been around this interest of determinants of health. And we've seen a lot where there are things that impact health outside of the clinician's office, so social determinants of health. And we've been focused in particular on information and how important information plays in that context, and information as a determinant of health. We know that people use information to make health decisions on an hour-by-hour, minute-by-minute basis. And we've really been thinking a lot about how do they receive that information as part of their daily journey. Platforms like ours, 2 billion people come to YouTube every month. That's almost a third of the world's population. So we know that people are engaging with us as they search and look for health information. Our goal is really to look at how we're able to bring that information, particularly quality information, to individuals around the world at scale. We've been particularly focused on this issue of health equity. In fact, last week we announced our Tackling Health Equity Through Information Quality program. We're going to be working with a number of organizations, in particular the National Birth Equity Collaborative, the Satcher Health Institute at Morehouse School of Medicine, the Loveland Foundation, to really tackle issues around health equity and how we bring information to light for underserved communities. And so, we look to partner and work with a number of similar organizations who have a similar ethos. So happy to be a part of this event and bringing this event to life, working with the STAT team. But I'm more personally excited about hearing from Dr. Bibbins-Domingo about her thoughts, future, and plans with JAMA, as well as her prior experience. And many of us are very familiar with around health disparities and health equity research. So with that, thank you for having me, and I'll turn things over to Usha Lee McFarland for more.
Thanks so much, Garth. And well, I'm personally thrilled to be here having this conversation today. I've known Kirsten since 2020, when as professor and chair of the Department of Epidemiology and Biostatistics at UCSF, she became a trusted voice to help me and so many reporters in California and elsewhere understand what was unfolding with the pandemic. This year, she of course made history. She became JAMA's 17th editor and the first person of color to lead that institution in its nearly 140-year history. So I'm thrilled to be talking about her career, her plans. And I want to start, Kirsten, by asking a little bit about your beginnings in science and medicine, you describe yourself as a data nerd. And I know you always center science, and it's almost in every sentence. And anything you talk about the importance of science. You clearly have a passion for it. So I'd love to know where that started. Can you tell us a little bit about where you grew up, what your parents did, and how and when science may have captivated you as a young woman?
Sure. Thank you. And thanks for having me today, Usha. I really appreciate it. So I am a science data nerd from way back. I'm an Army brat. I grew up all over. And I was fortunate to have a really great science teacher in junior high, and then to go to a science technology public high school in Maryland. And I think I'm lucky, like many people are, to have just had really great teachers who were role models, who got me excited about science. And I could see in them a way to continue on in science. And so, yes, from the very early on and throughout all of the things I've done in my career, science is really at the center.
That's great. I only recently learned that you earned your PhD in the lab of Harold Varmus, who of course is a Nobelist, former head of not only NCI, but NIH. And so I'm just wondering if you can talk a little bit about that experience. And given that you were in, a rarefied place working on critically important questions about cancer genetics, why did you not pursue bench science? And what was it that pulled you towards more clinical work and epidemiology?
Yes. So I started my PhD at UCSF and was fortunate to join Dr. Varmus's lab. Harold had won the Nobel Prize a month before I joined the lab, so there's no correlation between me and his Nobel Prize. But with Dr. Varmus's lab, really instilled the excitement about science, but also helped me to think about sort of the broader issues. And for me, the science was always core to what I wanted to be doing. But for me personally, I also wanted to see its relationship to its impact on human health. I was really fortunate and continue to be fortunate that Harold has been a mentor for me over the years, was very encouraging when I, after finishing my PhD, decided to go to medical school. He himself is an MD, and I think he himself is a role model for somebody who is deeply rooted in the science, but is interested in the institutions that help us to do science better. And you can see that in his public service as well. For me, it was about the translation of science to actual things that impact human health. And I think I could personally, for myself, do that more by doing more clinical and population research in addition to taking care of patients.
Wonderful. And I know you, even as you take the helm of JAMA, you hope to continue your research collaborations, and you're an internist, you're an expert in cardiovascular epidemiology. You want to continue treating patients. So can you tell me how you're going to make time for that, and why it's important? How do you see that informing the work you do, say, as the editor of JAMA?
Yeah, so I'm on leave from UCSF, the University of California, San Francisco, where I have been a professor in the Department of Epidemiology and Biostatistics, as well as the Department of Medicine. And I'll continue to be, although I'm full-time now at JAMA. But I will continue twice a month seeing patients with residents at a clinic that I've been caring for patients ever since I was in medical school and started in medical school at San Francisco General Hospital. I really do think that even though clinical work has not been the majority of how I've spent my time throughout my career, it has been a critical piece of how I spend my time. And there is nothing the same. There's nothing like communicating to a patient about why a decision is important, or your recommendation for a patient, hearing from them what's difficult about a particular health challenge they have, or a particular recommendation that we have for them. And I think it gives you context to understanding why the great science that we produce doesn't always translate into improvements of health, and where all of the barriers are, particularly in the clinic I care for patients, which are patients that are oftentimes are less well resourced than other patients.
Wonderful. And I want to remind our viewers to please put your questions in the Q&A because we'd love to hear questions you have beyond what I'm asking, Kirsten. So of course, we need to talk about your exciting new job, which you started in July. You know, it really is one of the most powerful positions in medical publishing. It's a journal that so many clinicians and journalists, members of the public rely on for information. I guess first, I want to hear about your plans, but I'd also like to talk about that difficult period that kind of has sparked so much change at the journal. I think most everyone here is probably aware of this podcast that questioned if there even was racism in medicine, or how could doctors be racist because they care for people. It sparked outrage and boycotts and petitions. Can you talk about how you personally processed that when you heard of it? I mean, it must, given your deep roots in health equity work, it must have also been personally painful for you.
Right. So I think that was an issue that many people heard about and know about. I don't think that it is an issue that is unique to JAMA and it is not certainly unique to medical and scientific publishing. It is a strain that we see throughout the biomedical enterprise. And it is one that is, we have to continue to have all of the voices at the table to understand what are the forces that shape health, how do we have discussion about those, and how do we do them in a way that advances the health of our patients and of all of our patients. The one thing I learned, as you mentioned at the outset in this pandemic, is how important it was for people to communicate about science and to communicate about the health impacts for all of the people who might be impacted during a public health emergency like the COVID-19 pandemic. It became clear to me how important communication was, how important it was to have many people communicating and shining a light on the health issues that were being faced by different communities throughout the pandemic. And so when the opportunity arose to think about leading this really quite extraordinary platform of JAMA and the network of 13 journals that are the JAMA network, it seemed like an opportunity to take what was increasingly important to me in my role at UCSF and to play a role in leading an organization that really is at core for communicating about science and being a trusted voice for science to so many in the clinical and public health communities.
When you were announced, there were just so many people who said, she's perfect. Like this was the perfect candidate. This is the person to lead JAMA. Her voice is so strong. But you have said you didn't think you were going to get the job. Can you talk a little bit about that?
Well, I have to say, and I think I've said this publicly, I didn't think I would like interviewing for this job. I didn't think I would like the organization, and I didn't think they would like me, frankly. I haven't been an editor of a major journal. I've spent most of my time trying to get my science published in JAMA, frankly, and other major journals. I knew I had a perspective and I had a clear idea of what I thought was important and what I could bring to an organization. I have to say, during the process of interviewing, I was extraordinarily impressed with the organization, with the people who are working to put out JAMA and these many journals that make up the JAMA network. Their commitment to thinking about how to continue to improve the journal and to be at the cutting edge. And it became clear to me that I could, with my experience, with my expertise, with my background, bring something to make an already strong organization better. And so I was surprised. I sort of applied on a whim, but it became clear to me that this was a good decision for me at this stage in my career to take on a new leadership challenge and to do it in a way that I think that will have an impact in how we communicate about science for the betterment of medicine and public health.
That's just fascinating that you almost didn't apply. I didn't know that. You have said you want JAMA to stand for something. Can you tell us, like, what is it you want JAMA to stand for?
Yeah, I think JAMA has always been a trusted voice for science and for medicine, and I think that trust is critical. Authors trust us with their science. Readers trust us that our peer review process and our editorial process is putting out high quality science. And as you say, we are a voice that many in the lay public and in others who also communicate about science, as STAT does, that what you read in science helps you to understand what you read in JAMA, or the JAMA network of journals, helps you understand something new about science, its translation to improving the health of patients and the health of communities and populations. So trust is core. What I want to do with our incredible team here is to continue to turbocharge JAMA and the JAMA network. We want to be the network that is really publishing the state-of-the-art science, the best science that is going to shape clinical care and shape public health. We live in an extraordinary time where the tools to actually do impactful science are everywhere, and they allow us to ask and answer questions in the ways we haven't done before. Clinical trials are a bedrock for the science that we think about and want to be publishing. We also know that there are more data sources that can help us to think through other questions that are important for clinical care, but we've not yet been able to answer in our traditional ways. And so we want to be a journal that is at a network of family of journals that is at the cutting edge of where science is taking us, and to be able to attract and publish the best science that has an impact on medicine and on public health. At the same time, we know that that the scientific discoveries are not enough. They always sit in context of the issues that shape how we think about it. You heard Dr. Graham talk about the social factors that shape health. We know that many of the policies that are happening locally or at the federal level also shape health, and they shape science. So the context in which science occurs is also important. And we want to be able to communicate that all to the broadest possible audience. The one thing that I've learned through the many leadership opportunities I've had is that when you think you're communicating just to a small audience, you're almost always wrong. You're always communicating at all times to the broadest possible audience. And so we want to be at the forefront of how people are communicating how people are consuming information about science, about health, how they're viewing the trusted sources, because we know we all have information overload all the time, and how people can get trusted information in the best way possible. And so those are the opportunities I see. The building blocks are all here at JAMA and the JAMA network, and we just want to take it to the next level.
Let me ask you about health equity. You've talked in many aspects of your work how health equity is not of course we have journals just about health equity research, but you've talked about how health equity shouldn't be siloed. It should really be sort of centered and part of all of the work. Can you talk about what you're doing to bring that mentality to JAMA? And what do you say to those people that were so upset? The people who said, I'm not going to send my work to JAMA, or JAMA's never respected health equity work. They've run editorials, but not research science on the field. We've always been sort of denigrated to a second-class citizen. What do you say to health equity researchers? How are they going to be brought in or part of what the new JAMA?
Yeah, I think you'll see this in multiple ways. The first and foremost for me, the authors who publish in JAMA, the authors who want to publish in JAMA, the authors who think they should have published in JAMA, the author community is a critically important community for me, as well as the readers of JAMA. And we want to hear from them about their experience, and you'll see more from us over the next coming period about really trying to understand how we best, how we as a network of journals are read, how we're perceived, the experience of authors. So you'll see more to come. For those authors who have an experience, or in many cases, it's just a perception, frankly, about the journals, we also want to hear from them. It is what helps us to improve. we can't do our work as medical and scientific journals unless we have relationships with authors and with readers. And that you'll see a strengthening and really a sort of dialogue, I hope, back and forth to really understand that more. I want, JAMA has already taken steps, and the network of journals have taken a step to make equity really front and center in the way the editorial teams are organized. Each of the network of journals have a DEI editor. The JAMA, the flagship journal, just recently named Dr. Preeti Malani as our deputy editor, who will focus on DEI activities that will include at JAMA, the flagship journal, as well as the activities across the network. But as you said from the outset, Usha, for me, equity is not something that we put to the side and that we also do as like the fourth thing that we do in a checklist of many things. It is something we really have to infuse in everything that we do. So when I think about, and I've written about this in the pandemic, part of the reason that we weren't quite as successful in many of our policies in the pandemic was because the equity issues were not front and center. They were also oftentimes the issues we thought of after we had done everything else. And I think for much of what we think about in health, much of what we think about science, what we think about where the barriers are to actually allowing scientific discoveries to improve population health, the failures when they happen oftentimes stem from not realizing that there are large segments of the population that don't actually benefit from a particular discovery, either because of access issues, because of other competing priorities, because of policy issues, because of the way we communicate about it. And so equity has to be front and center in everything that we do. And so while I think that naming DEI editors is critically important to state equity as a priority, as important for me is that these editors are part of the teams. They are part of our discussions of every manuscript that we publish because we want those issues related to equity to be part of everything that we do.
Let me ask sort of the converse side of that question, which is, there are a lot of critics of the new focus on diversity and health equity. And, some people say it out loud and some just think it, that bringing in diversity or focusing on these issues will lower the quality of the science. I'm sure you have heard some of these, in your new position. Can you talk about, how you answer those questions and what you think about that viewpoint that somehow diversity in medicine will reduce its quality or benefit?
Yeah, I think that that there are many voices in this discussion right now, and many people who talk about, well, the pendulum has swung too far this way or this way. I think the issue that is front and center for me is that we have a responsibility to publish science that helps us take care of all patients, to think about public health and the health of all populations. And in order to do that, we need many types of science. We need to have teams of reviewers and editors who are able to evaluate a broad range of science. And we have to think about the science that is going to have the impact on the largest segments of the population that we really want to be able to communicate science for and to communicate with. And so I think that that more voices in the room, to both as authors, as reviewers, as editors, really helps us to find the science and communicate it ultimately in a way that has the largest potential to improve the health of all of the populations that we'd like to improve. And so I don't, for me, see a conflict between these, and I think oftentimes the conflict stems from a sort of misunderstanding, a misreading, or thinking of this as a zero-sum game. This is not a zero-sum game. Improving the health and finding the best science, that really, everything about finding the best science and everything about improving health really starts and ends with the ability for all of the voices who might have outstanding science or might have perspectives on improving health are at the table in order to do that.
Thank you. So I know Dr. Otis Brawley, who chaired the search committee, said one of the reasons he was in favor of your leadership was he saw how you acted and responded when you led the U.S. Health Services Preventive Task Force, which at times became very political with the late Representative Dingell and arguments over at what age women should be getting mammograms, and how you kind of, again, returned to the science. I'm guessing that there's difficult decisions, difficult conversations being had about race and health equity. I know you've said even at UCSF, sometimes there are tears and shoutings because these are difficult issues. And I think it gets back to maybe the podcast and this idea many people, doctors are schooled and educated to help people. That's why they go into the field. So it seems, that it goes against what being a doctor stands for. Can you just talk about, what your background brings to this and how you having a lot of these difficult conversations, as the nation is since 2020 in this new position? And is it about education? Are there still tears and shouting? How open and vocal are these discussions? How willing are people to engage in this?
Right. One of the things that I learned so I joined the task force in 2010, and that was at a time when our mammography recommendations had come out, and there was a lot of controversy, a lot of name calling, and I think what I learned in that during that time was that part of the controversy stemmed from the fact that as the task force was putting out its recommendations, it didn't realize that it was communicating to many people. It thought it was communicating just to primary care providers. And so it had tailored a recommendation and used language that really spoke to primary care providers, but didn't necessarily speak to women who were concerned about their breast cancer risk, didn't speak to policymakers who were making decisions about the Affordable Care Act. And I think much of the work of the task force over time has really been in creating stronger partnerships with the many stakeholders who might be impacted by a particular recommendation, in thinking more deliberately about how it communicates broadly. I have to say, under my leadership, the U.S. Preventive Services Task Force, when I led it, moved to JAMA and the JAMA network, and now benefits from this broad, the network of journals to communicate the recommendations, as well as to publish editorials that sometimes question parts of the recommendation statements. What I've learned is that communication is important, leaning in is important, not being afraid of the controversy, but having the conversations with people in a way that people start to understand the different points of view. It is what we've done at UCSF. Before I started this job about a year ago, I organized a series on racism and race, thinking about the role of race and racism and in clinical medicine, and what how we think about and talk about race. My goal in doing that was to bring scientists and clinicians together who have been thinking in different ways about racial categories and how they're used in the practice of medicine. And what I think is often lacking is to bring differences of opinion to the same table. I would say, as clinicians, we want the best for our patients. As scientists, we want to do the best science that uncovers some important truth about the way science and medicine works. And I think the challenge is when we sit in silos, that's oftentimes exacerbates these issues that have become so unfortunately polarized. So in my experience, I will just say, for me personally, I'm not worried as much about the controversy. I'm worried more when we shut down and retreat into our silos and don't have the discussions, especially when we have the shared goals of improving health for our patients, improving health for our communities, and in thinking about how to do the best possible science.
Great. Thanks everyone for the questions that are rolling in, and please continue to ask those. It looks like a lot of people are more interested in JAMA and issues of publishing there. One question, you've talked about increasing and growing JAMA. What efforts are in place to lift the voices of authors from lower income countries, lower and middle income countries?
Yeah, it's a really great question. So the great thing across our network of journals, 13 journals, 13 journals. JAMA is the flagship. We have multiple specialty journals that have particular focus. And then we have an open access journal, JAMA Network Open, which is a fully open access journal and really publishes really outstanding science and a breadth of science. So we want to be encouraging, and we are encouraging submissions globally. We get submissions globally. And for those for whom sometimes fees for open access journals might be prohibitive, we have a policy that those fees do not apply. So that barrier shouldn't be a barrier to publication, for example, in JAMA Network Open. And I would say that our editors are very conscious of the things that we'd like to be doing to make sure that other potential barriers, that we're reviewing science fairly, regardless of where in the globe the science is done. And I think we've increased our efforts at doing that. I would say all journals want to make sure that their pool of reviewers is drawn from as broad a background as possible. We've talked a little bit here about race and ethnicity, but I would say broad backgrounds includes different scientific disciplines. It includes different parts of the globe. And we've been cognizant of trying to make sure that our reviewer pool represents that. And I think you'll continue to see efforts to improve that as well. So in order to lower barriers for people from lower resourced countries, I think it means that we have to make sure that we can attract it. And so barriers like open access fees are not a barrier, but we also have to make sure that we have a reviewer pool that can evaluate that science fairly. And we have efforts on both fronts.
That's great. Well, let's talk about open access for a minute. The White House recently announced that all federally funded research, which is a large proportion of papers published in JAMA and other top journals, have to be open access. And I've heard, the editor of New England Journal has addressed this as being concerned about what we'll do for the business model. People at Science Magazine are saying that they're not sure the impact yet, but will largely be big. How are you addressing it at JAMA or thinking about it there, how it really does change the business model for scientific publishing?
Yeah, when I became the editor-in-chief, my first editorial, I basically stated my commitment to open science and fair and equitable access to science. And that is a commitment. That's something that we have been thinking about, that frankly, the team here has been thinking about before I joined, but is a strong focus of mine that predates the OSTP announcement. Thinking about how we do that, I think is where we all are right now. So for me, the fact, I start with the first principles. The first principles is, do we want science to be as widely and broadly available as possible when we make a new discovery, when there is a new advance? Do we want to make sure that everyone is able to have access to read and understand that? We absolutely do. And that's a commitment you will see us already there with our open access journals. We have two, JAMA Network Open and JAMA Health Forum. You'll see us continuing to think through how we extend that access across our network. The other issue, though, that is also important is being a trusted source of information. And that is what you see the peer-reviewed journals trying to think through. How do we maintain those standards that are important for helping to vet the science as it then goes to be disseminated out to a broader audience. Science has to come out quickly, but especially for the science that we want to, that is used by clinicians to care for patients, we also want to know that that science is vetted, that we know that we have reviewed the science and that these findings actually are ones that we can stand behind. And I think that is an additional responsibility for those of us who publish for the medical and public health community, for people who are making decisions about patients and about public health. And then the last issue is issues of equity. And so we talked, your first question was about how people from low-income countries can have access to publication. That also applies to people who are from less well-resourced institutions in the US or who are earlier in their careers. And so we need a model for publication that really addresses some of these equity issues as well. And so while a lot of the specifics need to be worked out, I can assure you that it's a priority for us at JAMA and the JAMA network to make sure that we're part of the discussions that figure out how we can make sure open science and open access occurs in the best way possible.
We talked a lot about reviewers, and of course there's a lot of discussion of reviewers being overloaded, the people that do review doing too much of it, not being reimbursed for their time. We have a question. How do you view medical trainees and interns or even medical students playing a role in the research and publishing mission? Perhaps, as I know people, submit papers at different levels of their medical training, but as being reviewers or throughout the whole, process.
Yeah, thanks so much for that question. It might be because I spent my entire career at a teaching institution at UCSF. I spent a lot of time designing training programs, thinking and acting as a mentor, thinking about mentoring. So one of the things that I am really want to do and expand here at JAMA, and we already have in several of our network journals, is to have more trainees have the experience of scientific publishing and medical publishing. I think that this is such a critical part of the landscape of biomedical science, but is one that is oftentimes not as well understood for those who are sitting at academic institutions, for example. It feels like these are two separate worlds. And I think we would all benefit from those who are earlier at stages in their careers having the opportunity to spend a rotation here at JAMA, or to spend a few months here at JAMA, or to spend a year here with us. We already have one fellowship program, the Fishbein Fellowship, but I think you'll see us over a period of time sort of expanding those opportunities here at JAMA. And I will tell you already right now, for example, JAMA Internal Medicine has an opportunity for residents to be part of their editorial teams. I can tell you for myself that one of the most formative experiences for me early on as a scientist was being part of the peer review grant process to understand how the NIH actually gives out grants. It helped me to understand much more what I had to do to write grants. And I think the same way about medical publishing, that we would benefit from making the process a little bit more open and allowing those who are early on in their careers to understand the process, whether they're going to become authors in the future, or they might, some of them, want to be editors in the future.
Okay, we're coming near the end, so we'll try to get a few more questions in, and if you can answer briefly. JAMA is, of course, independent from the American Medical Association, but it's called the Journal of the American Medical Association. Do you see it as an American journal or a global one? Because one of our questions is, like, do you hope to increase, or how would you increase readership around the world outside of our own country?
Yeah, thank you very much for that question. I had exactly this conversation just a few days ago. So JAMA is a global brand. JAMA draws authors globally, and it is something that we do now in our readership. We know that we have a global readership and we have a global authorship. It is, though, not lost on me that this is a common misperception, that as the Journal of the American Medical Association, that we might only be interested or exclusively interested in things that affect US patients or scientists who perform science in the US. So I think we have to be just more clear on how we communicate about our interests. And I think you will see us doing that more actively now. We are very involved in global conversations about publishing, we're very involved with global communities who are producing outstanding science. But we recognize, and I recognize, that that is a common misperception. And so we'll just have to continue to do more.
That's great. My last question is, well, I'll urge everyone here on this call to read Dr. Bibbins-Domingo's editorial, The Urgency of Now, that she published right as taking the helm of JAMA. But can you, again, briefly, I thought it was so powerful how you talked about the collision of sort of where we are in science and the pandemic and publishing. It's left us at this crossroads. Can you talk about how important this moment is and where, like, you think we really need to go from here?
Sure. As you said, for me, the reason to make a decision to do something radically different than what I had been doing up to now really was about thinking about this collision where we have this outstanding science that's producing outstanding discoveries, translating them into outstanding interventions that help patients and help communities. And yet we still have gaps in our ability to do this. We, across the US, still have large, we don't achieve the health outcomes that are achieved in many other countries. And we also know that when we do achieve health outcomes that are favorable, there are oftentimes gaps so that they're not equitably distributed. And so we do have this really this big dichotomy between what we do on the scientific side and its translation into improvements in health. We have better tools, but we oftentimes don't have the ability to get those tools translated into something that improves health. And at the same time, things like the journals that are so critical at that interface, we live in an environment right now where we're in a little bit of information overload, that we can get information from so many different sources, figuring out who we can trust, what's out there that really will help us to understand a new discovery. It is also, it has never been more important. And so at this moment, when we really do have the best science, we really should, as a nation and globally, want to improve health for all communities. The important role of a trusted journal, a trusted network of journals to be there, to be the voice, helping authors to communicate their science to clinicians, to those making decisions about public health, I think has never been more important. And it is the goal I have for JAMA. It's my vision for JAMA and the network of journals that is the JAMA network, that we can basically draw on our history of doing it up to now, but really thinking about in this moment doing even more than we have done.
Wonderful. Well, with that last thought, I think we're out of time. I want to thank again Kirsten Bibbins-Domingo for joining me today, for answering some really good questions. I'm sorry we could not get to them all. I want to thank our event sponsor, YouTube, and all of you for taking time out of your day to join us. Our next and final virtual event, Status List event, will be on December 6th, and we'll be announcing our featured speaker in the coming weeks, and hope you'll join us. You can find